that PARP inhibitors is being talked a lot. Recently at GU ASCO, we saw data from TALA-PRO2. We've seen studies from you. How are you making sense of PARP inhibitors for everyone versus just using it selectively for patients that have BRCA, PALB2, or homologous repair defect mutations?
Yeah. Number one, at the moment, all the PARP inhibitor approvals in prostate cancer are around patients with HRR gene mutations. Each drug and each combination has a slightly different label. So there are nuances about which genes qualify and that, it's kind of too long to list out, but it's something you got to pay attention to when prescribing for an individual patient. The most common HRR mutation in prostate cancer is pathogenic variants of BRCA2. Two variants are about six-fold to seven-fold more common than BRCA1. On all clinical trials, the best responses are in BRCA2 mutant disease. The responses with BRCA1 are significantly worse. And then you go through the list of genes, gene by gene, there's different levels of response, and it varies tremendously. And, BRCA2 drives most of the responses. These are the ones you could feel really good about. I would say unequivocally, every BRCA2 mutant patient, you have to be thinking, when is he going to get a PARP? In your planning of the patient's treatment course, where is the PARP going to fit in? It's a miss if you don't give it because it's so highly effective. BRCA1, less impressive. The nuance I'd pull out, I'd say a couple of things. ATM mutant disease doesn't respond to PARP inhibitors. We have the recent meta-analysis using patient-level data from the FDA. The hazard ratio is 1, despite what the labels say. Right. I don't use PARP for ATM mutant disease. Check 2, I wouldn't do it. CDK12 is the interesting case. You could go to the FDA paper, especially with talazoparib, somewhat with olaparib as well. There's a response to CDK12 mutant disease. I think that's underappreciated because CDK12 mutant disease is bad. These patients progress fast. They're resistant to most therapies or poor responders. The fact that now there's some PARP inhibitor data, I'm trying to steer all my CDK12 mutant disease patients to tala-enza generally. You can also do olaparib. So, that's olaparib abis. Now, the question about HRR non-mutant disease with the TALA-PRO2 data, at the moment, we don't have approval for that in the United States. Going to be very interesting to see how the FDA treats this data. If you strip out the BRCA and the HRR and just look at the HRR wild type disease, yes, there was a positive signal in TALA-PRO2, but the hazard ratio still crossed 1. It wasn't quite there. Really debatable, right? I wouldn't place any big bets on where the FDA is going to go with this. I'm not sure.
Right. I think the heavy utilization will still be in the space of HRRM, while wild type is definitely questionable.